Right, good evening, everybody. Thank you so much for giving up your evening to join our webinar. So this is one of our monthly scan.com webinars, which we've been hosting now for about a year. My name is Dr. Lizzie Tuckey. I'm the Managing Director of the UK scan.com. For those of you who haven't joined before, we are like the booking.com of the imaging world. You can book a scan through our platform, accessing spare capacity across the UK. So it doesn't matter where your practice is, you can get a patient scanned in a centre near them or that's near their work. If you want to refer a patient today, you can click on this QR code and you can create an account really easily, but you can also refer directly from our website if you would like to. And just a little plug, our networking event at the end of summer in our offices, very trendy offices in Brixton. You're all invited on Tuesday, the 12th of September, and drinks and nibbles will be provided. And we'd love to see you in person. And then just a note on housekeeping, please, this is an interactive session, and ask questions and we can have them answered by Ian during the session. And we will provide certificates of attendance afterwards. So without further ado, I'm delighted to announce our guest speaker tonight, who is a very senior orthopaedic consultant, Ian McDermott, whose sole focus is on knees, and he's the honorary professor at Brunel University. So thank you so much for giving up your time, Ian, and we'll look forward to hearing from you. Over to you. I'm going to stop sharing my screen now.
I'm just going to share my screen, and hopefully that is working for you. Can you see that, Lizzie? Brilliant. Okay. I can't actually see on my screen at the moment the chat. Let me just there you go. I've got the chat up as well. So welcome, people. This is, I don't know how long exactly we've got, about an hour or so, something like that, to chat about knees. It's supposed to be interactive, so if you can type your questions in, Lizzie's going to keep an eye on the questions, and if there's anything particularly pertinent, Lizzie has said that she will pause me and we'll answer the questions as we go. Otherwise, what we'll do is we'll collect questions at the end, and we'll have hopefully have time for a nice chat and a nice discussion at the very end. So in terms of myself, just to introduce myself, my name's Ian McDermott. I'm a consultant orthopaedic surgeon, and I specialise in knees. I do nothing but knees, done nothing but knees for many years now. It makes me feel quite old when Lizzie refers to me as a very senior orthopaedic surgeon, but hell, you know, I'm looking at it and feeling it, so that's fair. So I'm based at in a group practice called London Sports Orthopaedics, and our main clinic is at 31 Old Broad Street in the middle of the city, and our main base for operating is at London Bridge Hospital, which is a superb private hospital right just south of the city, right in the middle of London. So what are we going to cover? First of all, we're going to talk about red flags. There's not that much to say there, but we're going to go through that. Second, we're going to talk about when to actually refer for imaging. Then we're going to talk about the benefits and the limitations of imaging. And then finally, just briefly about when to refer to a knee surgeon. So first of all, red flags. Well, thankfully, there's not that many. So there's not that many emergencies in knees, certainly not in elective knees. We're going to talk about just a few things: the red, hot, swollen, painful knee, the severe acute traumatic knee injury, and then the locked knee. So the red hot swollen painful knee, if somebody comes into your clinic with a knee that looks like that, then it's not appropriate to refer them for imaging. They need to be referred for an urgent appointment immediately. This is not something that you send a letter. This is not something that you would send an email. You pick up the phone. That patient's got to go to either they've got to go to either A&E, or if you've got a friendly and available local orthopaedic surgeon, you can see that patient that day, well, then you can book them an urgent appointment. That patient has got septic arthritis until proven otherwise. The other possibilities, it could be an acute inflammatory arthropathy, like an acute attack of gout. If the pain and swelling are localized or more focal, and they're focused at the very front of the knee only, and the rest of the knee is looking okay, well, then it could be a septic prepatellar bursitis, or it could even be an aseptic, severe inflammatory prepatellar bursitis. You're not going to know until you've stuck a needle in and aspirated that joint. You need to aspirate the knee. You need to get a sample. That sample needs to be sent off to microbiology. And if you think it's infected, the patient's going to need an arthroscopic washout that day. Or if it's just an acute attack of gout, then the patient's going to benefit enormously from an aspiration and an injection of corticosteroid. So if a knee comes in like that, the patient is going to be in severe pain, they're looking unwell, they don't want to walk, they don't want to bend their knee, incredibly tender knee, just refer them straight away, no messing around. That's actually a picture of a knee from the front. That's not a side view, that's a front view. Somebody presents like that. Again, you're not going to mess around. That's a dislocated knee until proven otherwise. And don't forget, when you see a knee that looks deformed, you're not necessarily looking at the maximum amount of deformation that occurred at the time of the actual trauma. So you have to assume that the injury is bad. And if there has been a dislocated knee, then that's associated with major neurovascular damage with an incidence of anything up to maybe 40% or so. So you don't mess around. That patient needs to go to A&E straight away. So, and if you leave it too long, and if there's bits of bone protruding, then you can get skin ischemia, then you may get skin necrosis, and then you may convert a closed injury to an open injury. Also, if the patient's got no pulses, then obviously that's an emergency. And then finally, the locked knee. Big difference between a fixed flexion and a locked knee. Somebody who hasn't been able to bend their knee for a long time and it's just gradually, slowly getting more and more bent, a greater kind of inability to extend the joint, well, that's a fixed flexion, and that develops with osteoarthritis. If somebody was able to straighten their knee and then there's an event, they twist, they turn, there's a pop, they feel something go in their knee, there's pain, there's sudden sharp pain, and then they can no longer fully straighten their knee, well, that's a locked knee. Again, please don't mess around with that. I don't think it's appropriate for people to try and manipulate the knee. And even if you can manipulate the knee and pop the meniscus or whatever's out of place back into place, then it's still an urgent referral. You haven't cured their knee, you've just unlocked it. But the best thing to do is an urgent MRI scan. So urgent referral. It's not an emergency, it doesn't have to be done within 24 hours, but ideally that patient needs to be seen within a few days, not weeks. They're going to need an MRI scan, again, within days, not weeks. And if there is a displaced locked bucket handle meniscal tear, then they're going to need an arthroscopy with an attempt to try and repair that meniscus if possible. So anytime a patient presents to you with a locked knee, then it is a displaced locked bucket handle meniscal tear until proven otherwise. If you leave a displaced locked bucket handle meniscal tear, then the longer you leave it, the displaced fragment gets macerated by knee movements, and also it scars up, so it retracts. So it becomes harder and harder to reduce the bucket handle fragment back in place, repair it, and therefore retain and salvage that meniscus. So generally speaking, this is just a broad kind of guide. It's not a hard and fast rule. If you manage to catch, reduce, repair a displaced locked bucket handle meniscal tear within the first 6 weeks or so, sorry, let me say that again. If you catch it and operate within the first 6 weeks or so, then there's a reasonable chance that you'll be able to reduce and repair it. If you leave it much more than 6 weeks, then the likelihood of it being reducible and repairable diminishes massively. So again, this is something that needs to be dealt with within a few days or maybe 1 or 2 weeks, but not left. So again, urgent MRI scan, urgent referral. This is an MRI, and here you can see the lateral meniscus, anterior horn, medial meniscus, reduced volume of the body portion of the meniscus because there's a fragment sitting over here stuck in the intercondylar notch. And this is that same lady's knee at arthroscopy a few days later. Here's the ACL, and this is the meniscus, the medial meniscus sitting at the front of the knee, flipped over instead of going around the edge and the back. So that's easy. That's red flags in the knee. There's not a great deal to say there, thankfully. But let's move on to what's more relevant for this evening. And we're going to talk about when to refer for imaging. So if this is you, then generally speaking, if you're not quite sure of the diagnosis, or If the patient's not responding to treatment based on your presumed diagnosis, well, then you're going to want to get more information and you're going to want to refer for imaging. If it's me, then the answer is pretty much always. So if a patient's bad enough or cares enough or is worried enough about their knee to justify coming to see me as a knee specialist, well, then I'm pretty much always going to get imaging. It's quite rare. In fact, it's really rare that I won't. Now, we'll talk in a minute about the value of clinical diagnosis and clinical acumen versus imaging. But from my perspective, I do nothing but knees. And even then, even based on taking a really detailed history and a really careful clinical examination, I would never, ever presume to know with any real certainty what's going on inside somebody's knee without actually looking. And you haven't looked properly unless you've done imaging. So for me, pretty much always. So there's a poll here. How often do you refer patients for imaging? 1 a month, more than 5 a month, more than 10 a month, or hardly ever? So if you could all click your answers on that, please. And let's move on.
You actually can't see the results, but the last poll, just to let you know, we did a poll for other specialty areas, and you've got 27% of people on the call are an osteopaths, 23% are sports physios, and 46% are physiotherapists.
Okay, cool. Good. And have you got your poll results yet for how many people, how often people refer for imaging?
Not yet, but I will have very shortly.
Okay.
Still
okay,
open.
that'd be interesting. So give us a shout. Ah, there it is. So 53% 1 a month, 9% more than 5, only 2% more than 10. Oh, and 36% hardly ever. Okay, so not as much as I would have actually guessed. Okay, well, if you're going to talk about imaging, we've got to talk about what imaging. You've got to know what type of imaging. So first of all, good old-fashioned x-rays, they're really useful. And if somebody presents with an x-ray like this with a severely arthritic knee, then you don't need to do any other imaging. You don't need an MRI scan when you've got a severely arthritic knee like that. It's obvious. If someone presents with a knee like this with some medial OA, well, you can see virtually bone-on-bone contact on the medial side, but the lateral side looks okay. Well, you don't know that the lateral side is okay, and you don't know what the state of the patellofemoral compartment is unless you actually look again with imaging, which means you need an MRI scan. So I can work out, is that patient suitable for a medial unicompartmental partial replacement, or are they suitable for a total? Are they suitable for a realignment osteotomy? So lots more information available rather than just an x-ray. And if somebody presents with an x-ray and the x-ray report comes back or the images actually show that there's a little bit of arthritis, again, that doesn't really tell me much. Early arthritis, well, what does that mean? So x-rays are good, but they're just a basic starting point. Ultrasound's really good. It's really good for tendinopathies. So quads tendinopathy, patellar tendinopathy, good for fat pad, looking at fat pad inflammation. It's also excellent at looking at the ITB. And big advantage with ultrasound scan is twofold, really. Number one, it's dynamic. So you can move the knee, you can see things moving as you scan. And number two, it can also be therapeutic, because if you see something that looks suitable for an ultrasound guided injection, then you can go ahead and do the ultrasound guided injection then and there as part of the investigation. So it's investigation and treatment. So ultrasound is very, very useful, but it's only useful for superficial things. So I often see people who've got like a query meniscal tear and they've had an ultrasound scan. Well, that's just weird, right? It's just not appropriate. If you want to see inside a knee, you need an MRI scan. And that's a nice new shiny brand new 3T scanner. And with that, you can get excellent picture quality. And we'll have a look at some of those pictures in a minute. So for me, MRI, unless it's an old person with an arthritic knee, then MRI is really my go-to tool because you can see so much more detail on it. We can also get CT scans. We do far less CTs than MRIs, but CT's got its place. It's very, very useful. I use CT quite regularly actually for preoperative planning for custom-made knee replacements. But in terms of diagnostics, it can be quite useful. This is a CT of a left knee, and what you can see is here's the patella, and the tibial tuberosity is way off here. So you can imagine the patellar tendon is a big old angle here, and the quads tendon is an angle. So this patient's going to have a big Q angle, have a tendency towards lateral patellofemoral overload, increased risk of patellar instability. So if somebody's got patellofemoral instability and patellofemoral pain and a tibial tuberosity way over here, well, then you might think about a anteromedialization tibial tuberosity realignment osteotomy. So CT can be really useful. CT is also really, really useful for looking at rotational profile of the knee. So you can get the angle of the hip, you can look at the rotation of the distal femur compared to the angle of the ankle. So CT's got its place, but it's kind of a little bit more specialist when it comes to diagnostic value and indications. And then we've got more complex stuff like a bone SPECT scan. So that's like a bone scan combined with a CT scan. Bone scans show you areas of metabolic activity, increased metabolic activity, very sensitive but not very specific. But a bone scan on its own doesn't really show you very clearly the anatomy, it just shows you the vague area. So if you link a bone scan to a CT scan, then you've got your anatomy and you've got your bone metabolism. So this is a patient who has a medial unicompartmental partial knee replacement in place, and there's loosening underneath the tibial component, and you can see this hot spot here. And this might well not show up at all on x-rays, and you're not going to get any proper pictures with an MRI scan because there's a big lump of metal there. So bone SPECT scans can be very useful, but that's not the kind of thing that you guys are ever going to refer for. That's the kind of stuff that we do, and that's fairly extreme. So that's when to refer for imaging. And then in terms of the benefits and limitations of imaging, which we'll go into in a little bit more detail. So you do get some clinicians who are like, well, I don't need imaging. You know, I'm really good. My clinical history and acumen, my clinical examination skills are so good that I don't need a scan to know what's going on. Well, if that's you, then you're a better man or a better woman than I am. So let's have a little think about what do we mean in terms of accuracy. So the real terms we want to think about, to be more statistically specific in our language, are sensitivity, specificity, positive predictive value, and negative predictive value. So what does sensitivity really mean? Well, that's the proportion of people with a pathology that correctly give a positive result. So if a test is highly sensitive, then it means that you miss few, so you have few false negatives. What's specificity? So specificity is the proportion of people without a pathology that correctly give a negative result. So if a test is highly specific, then there's few false positives. Positive predictive value. So this is the likelihood of you actually having a pathology if you test positive. Negative predictive value, similarly, the likelihood of you not having a pathology if your test says negative. So these are all different ways of judging accuracy overall, but they're all very, very important. And I would put it to you that if you don't know the sensitivity and specificity, those are the main two that we tend to rely on, but the sensitivity, specificity, positive predictive value, negative predictive value of whatever test you're doing, whether that's a clinical test, whether it's imaging, whether it's a blood test, whether it's a PCR test. If you don't know those figures, then you shouldn't really be referring your patients for that test, because it means that you can't really interpret them in context. You don't really know the meaning of whatever results come back. So what's the kind of broad accuracy of clinical assessment when it comes to knee pathology? So this is a good paper, and this was in the Journal of Arthroscopy, which is one of America's biggest journals for knees and shoulders. So this study in 2003, they looked at the accuracy of joint line tenderness for diagnosing a meniscal tear. So Sensitivity, pretty good, 86%. Is it specific? Reasonably about 2/3. If you've got joint line tenderness, likelihood you've got a meniscal tear is only 59%. Could be other things. If you don't have joint line tenderness, the likelihood of that being correct, well, 75%. So these figures are reasonable, but they're a long, long way away from 100%. And if you see 100 patients and you get it wrong, you know, let's say 41% of the time, well, then that should kind of, it's quite a sobering figures, really, particularly if you are one of those people who's overconfident in your clinical ability. So what about McMurray's test? So how accurate is McMurray's test for diagnosing a meniscal tear? So sensitivity, 50%. I mean, it's going to miss 50%. Specificity, can you rely on it to be accurate? For specificity, 62%, really not great. Positive predictive value, 52%. Negative predictive value, little bit better, 60%. So quite frankly, McMurray's test is pretty rubbish.
Hey, could you just remind us, please, what McMurray's test is?
Yes, everybody does McMurray's test differently, and it's such a shame that we've immortalized McMurray, TP McMurray, because we should have confined him to the history books anonymously, really, because his paper called The Semilunar Cartilages, and it was in the British Journal of Surgery in 1942. Well, there's a fantastic statement in there, and he says, if you open up the knee, this is prior to arthroscopy, 1940s, so way ahead of arthroscopy, which only came into the UK in 1976. So if they thought you had a meniscal tear, and if it was symptomatic, they used to open up your knee and do an open meniscectomy. And so McMurray said, if you open up the knee in the suspicion that there's a meniscal tear, but if you find that the meniscus is intact, you should remove the meniscus anyway, so that they won't get meniscal tears in the future. So this is this is like 30, 40 years before people actually realized that the menisci actually had an important function in the knee. And then when you read McMurray's description of his McMurray's test, it's just garbled garbage, really. It's such a poor description. And that's why every single textbook that quotes McMurray's test and explains how to do it explains it differently. And every single clinician who does McMurray's test does it differently. So it's difficult to know exactly what McMurray's test truly is. For me, bend the knee up, put it into varus, put it into valgus, whilst actually rotating it at the same time. And really what you're doing is you're grinding the meniscal cartilages in flexion and seeing if you can provoke a sudden sharp pain, or if you can actually feel a click or clunk on the joint line. So if it just hurts a bit, well, it's probably not a positive. It's just, if it's just generalized pain, I wouldn't call that a positive. If you've got a painful knee and somebody grabs your knee and twists it, of course it's going to bloody hurt. So if you twist it and there's a sudden sharp pain medially or laterally, and with that you feel a click or a clunk on the joint line, well then I'd call that a positive test. But as we've seen, does a positive test mean they've definitely got a meniscal tear? No. So that's McMurray's test. And then moving on to ACL tears, because you think if you've torn something big in your knee, like an ACL, surely that should be really obvious. Of course you can pick that up, can't you, clinically? Well, hold on. Anterior drawer test, sensitivity. And this is a paper where they reviewed the literature and they looked at all the published papers that have tried to quantify accuracy of tests for ACL tears. So sensitivity, the anterior drawer test, massive variation in the published literature, anything from as low as 18% up to 92%. Specificity, better, 78 to 98. Lachman test, is it sensitive? Yeah, it's more sensitive, 63 to 93%. Is it specific? Yeah, it's better. But worst case scenario, let's go, for the worst results published in the literature, 18%, 78%, 63%, 55%, really not as good as you might have thought. So imaging is important. If you think there's a problem, you need to look harder. You need to confirm that or refute it. And if you're going to look, then quality is terribly, terribly important. So this is another picture of a Siemens Skyra 3T scanner, state of the art, absolutely beautiful picture quality. But do you know what your local scanner looks like? Do you know what type of scanner it is? Do you know how many Tesla it is? Some of these open MRI scanners, yeah, okay, great, they're good for claustrophobic people, but they're rubbish for picture quality. If there's 2 rings and the patient that stands in the middle, then the magnetic field is something like 0.5 T. If it's a limb scanner, so a nice small, not portable, but a much smaller scanner, again, really rubbish picture quality. So know your scanner, because the picture quality makes a hell of a difference. So
what scanner do you recommend for knee imaging?
right, for knees, I would straight away go for a high-res 3T scanner. There are some modern 1.5T scanners with modern software where the picture quality is almost identical. It's not quite as good, but it's very, very close to a 3T scan. So I think you just got to get to know your local scans. But that's very difficult if you don't look at the pictures, if all you do is just look at the report, which is a separate issue. So this is a 3T scan, and you can see really, really good picture quality. You can see the articular cartilage beautifully. You can see the meniscus beautifully. You can see the ACL there. You can see the medial meniscus, and there's a hell of a lot of information you can pick up from this. So even just on glancing at this patient's got a horizontal tear in their medial meniscus. They've got bone bruising on their medial tibial plateau. What else have they got? They've got a bit of irregularity, so irregularity around the muscular tendinous junction of popliteus. Coincidentally, they've got a little bit of a bipartite patella. They've got a little bit of degeneration of the distal quads tendon. So there's a hell of a lot you can see, and that's just on a sagittal views. So high quality MRI, really, really useful. Now, my heart sinks when people come to clinic and they turn up with a CD and they say, I've got, or sometimes, I kid you not, I've had people turn up with like a stack of 4 CDs. They say, oh, I've got my old imaging. Number one, the software doesn't always work. Number two, it can be really, really slow. You could spend your entire time with the patient just trawling through really, really slowly, go through the images. And number three, you don't know what the picture quality is going to be. So for me personally, if I'm going to see a patient in clinic, if they've had previous imaging, I want to know so that we can get their data from their previous scan, IEP, that's an inter-hospital electronic protocol, an IEP data transfer onto our imaging server so we can actually see it fast and look at it better. And if I can look at it beforehand, even better, because if it's a really poor quality picture, or if it's really old, then it means we can get some up-to-date high quality pictures in advance of seeing the patient, which saves them time. So that's a picture, that's an example of a scan I saw last week, I think it was, and the patient had been told that they this was a private hospital in London, not, I hesitate to say, not London Bridge Hospital, another well-known hospital, and she was told that this was a high-res 3T scan. It was going to be great picture quality. Well, it was rubbish. It was really, really poor. So poor that I would really hesitate to lend any weight to any comments in terms of diagnostic accuracy. Then you've got to think about your radiologist. Now, I don't think anybody said they were a radiologist, did they, Lizzie, in terms of who's actually listening? So
no radiologists.
Good, so I can get away with this. So I disagree with about 50% of the MRI reports that I see, to at least some extent or other. And if you're looking at an MRI report, well, then you're looking at the opinion of somebody who's sitting in a basement in a dark room with a screen in front of them, who doesn't know the patient, hasn't got the full history, they haven't examined the patient, and they're looking at the imaging in isolation, not in context of the patient. So a radiologist will inevitably practice defensively, which means that what they'll do is their report will list every single little thing that may or may not be of any relevance, because they don't want to miss something. They don't want to be accused of having made an error by missing something. So that's why I hesitate to give patients their MRI reports, only because there's going to be a whole lot of stuff on there that may be completely irrelevant, and then it may actually be wrong. So remember, it's just an opinion. And it's easy for me because I do nothing but knees. I've done nothing but knees for, you know, a few decades now. And I have so many MRI scans and I look at every single one myself, and I look at it in context of that patient. So I know the knee anatomy probably better than a radiologist. You know, you'd hope so. If somebody's going to have a knife and chop open a knee, you would hope that they know their anatomy. They bloody should. And I do nothing but knees, and whereas a radiologist may, you know, even an MSK specialist radiologist will do the whole body. And then the other big advantage I've got over a radiologist is that if the patient does end up needing surgery, then I've got that feedback loop in terms of I can correlate the history, the examination, the imaging, and what you actually find in the real world. So I've got one over on the radiologists. Now for you guys, you know, if you're seeing patients with back pain, hip pain, knee pain, foot pain, upper limb pain, etc., and you're sending them from MRIs, well then there's absolutely not a hope in hell that you'll ever be able to become a specialist in just one particular area. So I would never presume to give a professional opinion on a scan of a shoulder, of a foot or ankle, anything like that. I'm not even keen particularly to look at hips. So I would only just focus on one joint, the knee. Whereas if you guys have got to look at everything, you're not really going to get a chance to do that. So you end up having to rely on the radiologist. So even if the radiologist is brilliant, they can make mistakes. But what if they're not brilliant? So I use some fantastic radiologists, and even though I disagree with them, their reports on a regular basis, every now and again you'll see something weird, something unusual, something that you're like, what's going on there? In which case I pick up the phone and actually discuss it with them, and then they can be absolutely invaluable for those kind of things that you're not quite certain about. But who's your radiologist? Yep. Do you know your radiologist? Do you know who wrote the report? Do you know that they're a really, really good one? Or are they just random? And then sometimes you can see things that aren't there. Remember, it's just a 2D representation. It's not a photograph. An MRI scan is a 2D representation of the water content at each different pixel location. So it's not a real photo. And sometimes things appear to be there that aren't really there. Though, by the way, just so you know, nothing on that screen is moving. Right? It's a static picture, promise you. It's a static picture.
Great. Just a question on that.
Yeah.
How do you control who the radiologist is? You know, some of the people on this call only order imaging once a month. You know, do you recommend that well, obviously they should use scan.com, but how do you recommend they get to know who's reporting, and what's your strategy for that?
Well, personally, it's easier for me because there's a space on every referral form where you can actually, there's a box where you can actually tick which radiologist, you can actually write the name of the radiologist. And when I'm referring to patients specifically at London Bridge Hospital, there's only a small short list of guys that are on my list. So it's easy for me. For you guys, it's less easy, I'm afraid. A lot less easy.
Okay.
So then you may miss things that are there, you know, down to resolution issues, or, you know, and that may be even on the highest resolution scans. There may be things somewhere on the screen that you just can't see. You may misinterpret things. Did you get that first time, Lizzie? No, you didn't. Keep going. Try again. Now, did you get it? Okay.
I can't really.
I'll tell you
think
later.
I did.
It don't matter. It don't matter. Right. So we talked about accuracy of clinical examination. Yeah. Well, what about accuracy of MRI? And this is a really good paper. So MRI diagnosis of a medial meniscal tear. So sensitivity, 83%, specificity, only 68%, positive predictive value, only 58%, negative predictive value, 88%. So when people think that an MRI gives you the answer and it's the gold standard, well, quote this paper, remember this paper, remember those figures, varying between roughly 60% up to nearly 90%. Well, that's a very big error, right? What about the lateral meniscus? Sensitivity 83%, specificity 89%, positive predictive value 75%, negative predictive value 94%. So a bit better, but still not 100%. So what about an ACL? Must be absolutely barn door blatant obvious. Come on, this big piece of rope in the middle of your knee that's snapped. Must be obvious, mustn't it? Well, only 92%, 95%, 85%, 97%. So not guaranteed. So you're gonna get one wrong out of every 10 that you see, roughly speaking. Yeah, that's not insignificant. So where do we stand? Where does that leave us? Well, just a few suggestions. Number one, have a very low threshold for referring for imaging. I've seen on Twitter, LinkedIn, various kind of social media forums, lots of chat groups, people going, oh, no, too many people are referred for MRI scans. You know, well, that's, to me, it's almost like saying too many people look right, look left, look right again when crossing a road. You know, you should just cross a road with your eyes closed, just listening. No, that's daft. It's stupid. Imaging gives you information. Why on earth would you want to limit the amount of information that you get that guides your decision making? Yeah, it's just information. I think you'd be a bit of an idiot if you kind of didactically followed exactly what every MRI scan told you. And if you treat the report, if you treat the imaging, not the patient, well, then you're dangerous. Because looking back at those previous figures, there's a not insignificant error rate. But have a very low threshold for referring for imaging, for anything that you think might be significant. Do not believe everything you read on an MRI report. Generally, they're roughly right. I would say no more than that. And the imaging should be interpreted in context, and it's in context of the patient. Again, you treat the patient, not the picture. You treat the patient in terms of their symptoms, their functional restrictions, their aspirations, their personality, and in terms of what they want. You know, I've never yet run down the road with a saw and a drill in one hand and a knife in the other hand, kind of chasing somebody, begging to cut their knee open. You know, it's up to the patient. My job is to, number one, first and foremost, get a diagnosis. Number two, explain to the patient what their options are, pros, cons, guide them, and then number three, guide them through and assist them with the decision-making process if they require assistance. It's only then, number four, that my job then moves on to actually chopping people open and doing surgery. So I think knee surgeons, not just knee surgeons, surgeons in general, do themselves a massive disfavor by calling themselves surgeons. Number one, silly use of the word Mr. You know, that's a historical thing going back to the barber surgeons. We're not, we're doctors, okay? And number two, to call myself a knee surgeon, again, it's a misnomer because I only operate on about 25% of the people that I see, which means that 75% of the people I see in clinic do not end up with an operation, but hopefully as close as possible to 100% get a diagnosis and a treatment plan. So anyway, imaging should be interpreted in context. Next, trust your clinical judgment. If something doesn't feel right, then it's probably not right. And if somebody tells you, oh, no, the imaging's normal, then look harder. If you just had an X-ray, do an MRI scan. If you have an MRI scan and it's a low quality, low res one, well, get a high res scan because you'll pick up more stuff. And if it still doesn't feel right, well, then if in doubt, ask a friend. Okay. And that applies to me as well as you guys. I've got mates who are knee surgeons. There's a complex knee MDT group that's set up by the knee surgeons in Oswestry, North Wales, which is a great centre for orthopaedics. And once every month, there's a Friday lunchtime webinar where complex cases are discussed. A lot of the time, there isn't a clear answer, but you know, if you're not sure, ask a friend. And, you know, ask up the ladder to people who you think might have a greater level of expertise in that specific specialist area. So that's benefits and limitations of imaging. And we're nearly done because we're just going to talk about when to refer to a knee surgeon. So easy. If you think the patient needs surgery, well, great, refer them. If there's a red flag, well, then that's going to be an urgent. Don't write a letter, don't send an email, pick up the phone. If you can't get hold of somebody and speak to them in person, send that patient to A&E. If you're not sure of the diagnosis, well then, I do nothing but knees. I think I've said that about 10 times now. So I'm probably, this is where all the questions and all the angry comments are going to appear in the chat group. I hope that I'm probably better at diagnosing a knee problem than somebody who's not a pure knee specialist. I certainly should be. And then if the patient's insurance company, if the patient's improving, they're having treatments, but the patient's insurance company is limiting how many times you can see them, they say, oh no, you've got to get a fresh referral again from a consultant specialist. Well, that's fine, but make sure you tell us that in the referral letter, even if you say it kind of subtly and diplomatically. Because if I receive a referral from, for example, a physio, I'll assume it's because the physio is not happy with how that patient is. They're not responding and they want things to be taken further. So if you are happy and all you want is the patient to be referred back to you for more sessions, then please make it clear in the letter. And then if you just want reassurance or backup, there's reassurance is a form of treatment. Education is a form of treatment. So not just because you think the patient needs surgery.
And
yeah.
would you do video consultations, or do you always ask, because there's probably a range of people on the call from different locations, but if they knew it was more reassurance, would you offer that digitally, or would the patient need to attend?
Yeah, I do remote teleconsults. I'm a massive fan of them. At the same time, I absolutely hate them because they've got pros and cons. The good thing is that if I've got somebody, I get patients from all over the place, patients from recently from New Zealand, Israel, Holland, France, all over the place. And for those patients, it's really useful for them to be able to have a triage session to find out whether or not they're likely to be suitable for surgery, rather than come all the way to the UK to find out actually that they were never even vaguely appropriate. So that's really useful. I will never, ever operate on somebody without having met them face-to-face, actually seen them, examined them, had a chance to have a face-to-face chat with them. But for me, the video consult can be good triage. Bearing in mind that with a video, you lose a lot of the non-verbal communication when that's valuable. That's why masks, one of the many, 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 many reasons why masks were so ridiculously bad, because you lose that non-verbal communication and that damages communication skills, and that makes consultation less safe, in other words, more dangerous. And also you can't examine somebody. You can get them to go, oh, can you straighten your leg, can you bend your leg, etc. But you can't actually examine them, do a proper clinical examination via Zoom or Teams, etc. When it comes to follow-up, if you just want to have a follow-up with somebody, and if you want to just make sure they're okay, and especially if they don't live locally, then yeah, a remote teleconsult can be very, very useful. If somebody's doing well and they live 20, 30, 40, 50 miles away and they've got to come all the way into London and I go, how are you doing? And they go, fine. And I go, good. So yeah, teleconsults can be really important.
There's a question here which isn't bang relevant, but some patients are scared of open surgery. What keyhole surgery options do you offer so quicker recovery time? And I think for me that raises a broader point around physios and other healthcare professionals being able to understand the procedure that they might or might not be talking about when they refer to someone like you. So maybe you could describe, after you've answered that question, a little bit about some of the most common procedures and what the recovery times are and what the patients can expect, so that the people on this call have an idea of what their patients might be leading towards.
So right, arthroscopic surgery. So I reckon the quickest and easiest and simplest thing I could ever do is take out a loose body. It's like just taking a little pea or taking a stone out of your shoe. That's the easiest thing to do. trimming a meniscal tear. And if in the press a couple of years ago now, the press was full of these statements like knee arthroscopy doesn't work. Absolute bullshit. You know, the people who said that were absolute muppets, total clueless idiots. It's like saying cars don't work because as a vehicle it can't plow a field. Well, you know, duh, you needed a tractor. Okay, it's like saying telescopes don't work when you want to look for a bacterium. Duh, you needed a microscope. So arthroscopy is very important to appreciate. Arthroscopy simply means arthro joint scopy look. Arthroscopy is not an operation. Arthroscopy is a surgical approach. It means you're looking into a knee with keyhole surgery instead of opening it up. So the term arthroscopy doesn't tell you anything about why you're operating, what you're expecting to find, doesn't tell you what you do actually find, and it doesn't tell you anything about what you're doing inside the knee. So the list of things that we can do arthroscopically inside the knee is absolutely massive. And even with a degenerate meniscal tear in an older patient, in about 1/3 of those patients, the symptoms don't settle sufficiently with time. So in 2/3 they do. So the right thing to do with an older patient with a degenerate meniscal tear is wait, give them time and see whether it settles. If it settles, leave them alone. If it doesn't settle, and if those ongoing symptoms feel bad enough to them to justify the pain, the hassle, the risk of surgery, when they do an arthroscopy, in which case you're going to trim the torn meniscus. In a younger patient, we'll always try and repair and salvage the meniscus if we possibly can, because if the bigger the tear, the more damage there is to the meniscus, the more you have to trim it, the more meniscus you lose, the less of a shock absorber, the bigger the risk of arthritis in the future. So if you can repair a meniscus, you should. So, you know, meniscal repair is terribly important. If you've lost the meniscus and if the patient's knee's beginning to go downhill, well, then you can replace the meniscus. So we do meniscal transplantation, and we do that arthroscopically. Well, that's just not a quick little keyhole op. It is keyhole, but a meniscal transplant can take me 2.5 hours, and it's really, really, really fiddly. You can do microfracture. The modern version of that is nano drilling. So for small focal cartilage defects, you can do radiofrequency chondroplasty to smooth off and stabilize rough or unstable bits of cartilage. You can do articular cartilage grafting. So you can even do that arthroscopically with chondro tissue grafting as a single stage procedure. That's called AMIC, autologous membrane induced chondrogenesis. You can do anterior cruciate ligament reconstructions, posterior cruciate ligament reconstructions. You can do patellar realignment. You can, you know, how long do you want me to go on for? I think the polite and accurate and scientific term is shitloads. You can do shitloads inside of a knee arthroscopically. What you can't do is some of the really big stuff. So if you're going to do a focal resurfacing implant, then you'll probably do that through a mini arthrotomy. So you'll open up the knee a bit, but not massively. If you're going to do a total knee replacement or even a partial knee replacement, you're going to have a much, much bigger incision. So it's very difficult to generalize these things. And if you want to know what can be done arthroscopically, then go to a website called kneearthroscopy.co.uk. It's written by a really nice bloke with not much hair. And it's all about arthroscopic knee surgery. And if you want to know about knee replacements, then go to a website called kneereplacements.co.uk. Again, it's written by a really nice bloke. And it's all about knee replacements. So share those websites with your patients and it'll give them an idea about, you know, what can or can't be done surgically and what the actual surgery entails. And then really importantly, just to finish off the little presentation, is get to know your local knee surgeons, because with time, what you really want to do, and it's very difficult because you can't get to know everybody from every specialty, but what, you know, the golden nirvana, what you really want to achieve is get some knowledge of who the good guys, who the bad guys. You want to know, you want a surgeon that spends enough time with their patients to get an accurate, reliable diagnosis. So the last thing, I mean, I absolutely hate these surgeons who are conveyor belt surgeons who, you know, spend 10-15 minutes with a patient and just churn them through on a conveyor belt. I absolutely detest that. Commoditization of healthcare and treating patients as, you know, products is just appalling. You know, that's what American healthcare is, and we've got to try and resist that for as long as we possibly can. At the same time, try and keep clear of your crazy hacker surgeon who just wants to cut and chop everything. You know, people who've got an artificially inappropriately low threshold for chopping people up. Similarly, keep away from your surgeon who is bought, so who is a paid consultant for any of the orthopedic companies. Personally, I think that should be banned. I think that should be illegal in medicine. And also, you keep away from the ones who worship the god of money. If you think that your doctor is there for them instead of you, then you should run 100 miles. You should run away from them as fast as you possibly can, even if your knee is bad. Leg it, run. So that was the end of that presentation. Lizzie, I didn't have the...
Thank you so much. So questions are, do you believe the guidelines regarding MRI, CT, X-ray investigations are causing confusion about when to refer patients? And for those of you who haven't asked, please drop your questions into chat, and we'll go through them now.
I think guidelines are useful. I'm not aware of any guidelines at all, because even if there are guidelines, I'm going to completely, totally bloody ignore them, right? Because I know when to refer and I know what to refer for. Now, that's easy for me to say because that's all I do. If you're less experienced or if you're more generalist, then guidelines can be really useful. But remember, a guideline is not a protocol. Guidelines are just, they do what they say on the bottle. They guide you, give you advice as to when to do stuff or when not to do stuff. If you rigidly apply a guideline, then it's a protocol. And protocols are potentially very, very dangerous for the people on the far left or the far right of that biological normal curve. So they may be right for most people most of the time, but they could be completely the opposite and wrong for some people some of the time. So I think the more experienced you become in any subject, the less you need to and the less you will rely on guidelines.
Okay. And for those that don't refer a lot, there are support programs. But I think for MRI, the message I'm hearing today is that, it doesn't have any radiation exposure. So, use it as a data tool, provided, your patients need it. And then what importance do you attach to problems with plica, if I said that right?
Yeah, plica, a plica. So it's a little bit like saying you've got an appendix. If you've got a plica in your knee, lots of people got a plica. But if the plica is thick, if it's rubbing, if it gets inflamed and it becomes symptomatic, then that's plica syndrome. And I think that plica syndrome, first of all, it's almost a diagnosis of exclusion. I don't think it's massively common. It tends to occur in runners. It tends to occur in people in their 20s and 30s, and mainly in runners, sometimes in cyclists, sometimes in dancers, and it causes anteromedial knee pain. And if you've ruled out any other pathology, and if you can see a plica on the MRI scan, then it's reasonable to assume that they might have medial plica syndrome. Now, you can refer the patient for an ultrasound-guided steroid injection, and that can help in terms of diagnostic value and sometimes therapeutic, and sometimes it may actually cure them enough for them not to need anything doing. Or if they've got persistent plica syndrome and if the symptoms are bothering the patient significantly, for example, they're a runner and they're desperate to run and they can't run anymore because of that anteromedial knee pain, well then, if the patient feels that their symptoms are bad enough to justify the pain, the hassle, risks of surgery, well, then you could do an arthroscopy and just excise, shave away that plica. That's a really quick, really easy thing to do. The only time when I would say I have now got a confirmed definite diagnosis of medial plica syndrome is after I've got a presumed diagnosis and then we've trimmed the plica arthroscopically. The patient's got over the op, they've done their rehab, they got back to running, and then they email me to say, I'm cured. So it's almost like a retrospective diagnosis of confirmation after you've actually treated them. Yeah.
Thank you. Okay. So that answers your question, Sally. I think Sally had one more question. No, she didn't. Lucy would like to ask you, what do you think about robotic surgery?
Am I allowed to swear?
Yeah, I think so. It's
Yeah,
past 6 o'clock.
it's a load of old bollocks. I think robotic surgery is very, very interesting for kind of microsurgery. And I think that in the future, most surgery will end up robotic. However, in context of what we're doing today, the real question there, I presume, is, I assume, is robotic knee replacement surgery. Now, there are very big studies with very large numbers of patients that show, though, that robotic knee surgery does nothing to improve patient outcomes. So personally, I think the robotic knee surgery, it does have its uses. It does ensure predictability and accuracy of placement of the prosthesis. So you can guarantee you've got a greater probability that you'll put it in correctly and straight. Now, that's fine if you're using a standard prosthesis, but if you're using a custom-made knee replacement, which is what I've been using for the last 10 years now, this is not new tech. I've been using it literally since 2012. You have 3D printed custom-made cutting blocks that are as accurate as navigated or robotic surgery. But with a custom-made knee replacement, you've got a prosthesis that perfectly matches the size, shape, and contours of that patient's knee. With the robotic surgery, what they're doing is they're getting a standard knee replacement and they're putting it in very accurately. Well, they're placing it accurately, but the prosthesis itself might not accurately replicate the anatomy, the size, shape, and contours of that patient's knee. So it's almost like going to an expensive tailor and they measure you up, measure your waist, and they measure your inside waist, and they measure your leg length, and then they go, okay, these are your measurements. You can have that prosthesis on the shirt, hanging. You can have that suit that's hanging on the peg over there, and it will roughly fit. Well, that's the same with knee replacements. So if you want a knee replacement that is placed correctly, well, then you don't need robotics. You actually can do that with custom-made cutting jigs. And if you want one that fits properly in terms of size, shape, and contours, well, then it's got to be a custom-made knee. So I think the robotic knee replacement surgery, it's not just I think. If you read the literature, the published literature, it makes no difference at all in terms of long-term patient outcomes. Therefore, I'm afraid it's nothing more than just a marketing gimmick. So if you want to read more about that, look at the kneereplacements.co.uk website and look up custom-made knees.
Thank you. Makes sense, actually, to use the technology to design a perfect implant versus using technology to actually carry out an operation that's using a standard implant. Do you advise any of these for joint health? Is there value using cod liver oil, vitamin D, etc., etc.? And what are the dosages, please? That's from Claire.
Right, vitamin D, probably everybody should be on vitamin D. Allegedly, again, this is not my specialty, so I'm speaking a little bit out of turn here, but I vaguely remember hearing that about 40% of the UK population have got low vitamin D levels. So there's a strong argument that everybody should be on vitamin D. Get one of those vitamin D sprays and you just brush your teeth in the morning and then spray the vitamin D under your tongue. It's minty, so it's like a breath freshener. And probably everybody should be on vitamin D. It's important for multiple reasons. In terms of supplements, there was a very good meta-analysis published in the BMJ a few years ago now, where they looked at all the different supplements. They showed that glucosamine made no difference, chondroitin sulfate made no difference. The only thing that made a small positive reduction in joint pain was omega-3 oils. So probably a good argument, a reasonable argument at least, for taking omega-3 oils. And don't ask me about omega-3, omega-6, etc. I'm not a dietitian, so just omega oils, or even better, just eat oily fish a couple of times a week. But supplements in general, do they work? Not really. Not for knee arthritis, despite the fact that loads of people take them, and that's because they're marketed.
Okay. Thank you. So not a good preventative option.
Look, I've got no problem with them. You know, a lot of people go on
Yeah.
about turmeric. Lots of people go on, you know, if somebody comes in and says, "Oh, I use magnets and crystals," I'm like, "Hey, brilliant, good for you." There's no
And
point
it
in
works. So thank you, Claire. A question from Io. Wonderful presentation, he says. Would you carry out knee surgery on an overweight patient? I have a young patient who's overweight with an ACL tear, but the GP is refusing to refer her to a consultant because of her weight. However, she cannot lose weight because she cannot exercise. Stuck in that loop. What is your approach in this case? Thank you in advance.
Yeah, I've operated on many obese patients, some of them grossly obese, and it is technically more challenging, undoubtedly, in terms of the technicalities of the surgery. But BMI is not a contraindication to surgery. And it's very easy to say, oh, just, you know, tell them to lose weight. But as, I'm sorry, I lost the name of whoever it was that asked that, but as whoever asked that question pointed out, if they can't exercise, they can't keep their metabolic rate up, they can't burn off calories. And it's, you know, a catch-22 situation. So being overweight is not a contraindication for surgery. If somebody's got an elective problem, so if I see somebody who's older and they come in with an arthritic knee, I will do my absolute best to encourage them to lose weight. But it's not like I'm going to be the first person that's ever told them to them. It's not like if I say, well, if you could lose a few pounds, you have to put it kind of delicately and politely. But if you could lose a few pounds, then that'll put less weight through your knee, and it'll reduce your knee pain, and it'll also make the surgery easier, and etc. etc. It's not like me saying to them, they're going to go, oh my God, I never thought of that. You know, so these people have struggled with their weight for a very long time before they've come to see me or you. With the elective knee replacement patients, if they are properly obese, then there's an argument for referring them to a bariatric specialist for consideration of things like gastric banding or partial gastrectomy, you know, stomach bypass, whatever. And that can have a really big effect. And if they can lose weight, then yeah, their knees will probably hurt less. So that's a strong argument for suggesting that. And I reckon 1 in 20 of my patients actually accept my suggestion, even though I word it as carefully, diplomatically, and sensitively as I can. Most of my patients just don't want to go down that route.
Okay, no, that's very helpful. Actually, Stephen has asked a follow-up question on the question around supplements. What about Ostenil injections?
Oh God.
Same as before.
Right. All kinds of people inject all kinds of crap into knees, and quite frankly, they're doing it for their benefit, not the patient, because they're charging lots of money for it, and it drives me nuts. So there's a long list of things that people inject. There's high hyaluronic acid, and Austin is just one brand. Durolane, Synvisc. There's a whole list of different versions. They're all the same thing: high hyaluronic acid. If you look at the meta-analyses that have been published, it's no better than placebo. So the American Academy of Orthopaedic Surgeons, which is the biggest orthopaedic organization in the world, they actually removed high hyaluronic acid injections from their recommended algorithm for the treatment of knee arthritis several years ago. So it's not recommended. So very expensive, nothing better. It's no better than placebo, but it's got cost, and about 1% of people end up with an acute synovitis where their knee becomes very painful, hot, red, swollen, and that can take a week or two to settle. And then 1 in 1,000 people can have an anaphylactic reaction and end up rushed to A&E. So it's not without risks. So if there's significant risks, but with no proven benefit, no better than placebo, well, then you can't justify doing it. Same applies to PRP. PRP is even more expensive. Again, PRP stands for pointless rich physicians. You know, these people who just enjoy injecting A, B, C, D, E rubbish into people's knees. The craziest one I've heard is ozone therapy. And apparently there's an osteopath somewhere in London injecting ozone into people's knees, but that's bollocks. The worst thing, no matter how bad your knee is, and even if I say don't run on it, you've got a really bad knee, the one time I would say definitely run is if somebody offers you a stem cell injection. So unfortunately, there are dodgy individuals out there, the dodgy stem cell salesmen, who have got absolutely no scruples whatsoever. And what they're doing is they're doing periumbilical liposuction. They're taking the fat. They get about 100 mils of fat in a big syringe with ball bearings in it. They shake it like that, right, to smash up the fat. And if you watch that gesture, I think that's quite apposite for these individuals. And they smash up the fat, and then they leave it to settle. And then you take the top couple of mils of smashed buggery fat cells, and then you inject that into people's hips, knees, temporomandibular joints, whatever, and say, oh, it's stem cells and it's going to grow you a new knee. It's absolute bollocks. They're charging about £8,000 per injection, and it's I personally would describe it as criminal. So don't let your patients fall for that. It's an absolute scam. So
no ostenil. Good to know.
The best thing you can inject into a knee, sadly, the best thing you can inject into a knee is also the worst thing, and that's corticosteroid.
Yeah.
Now, the reason it's the best thing is it's dirt cheap, it's really easy, it's very low risk, it's a very powerful anti-inflammatory, it can last months. The reason it's the worst thing is that all it does is mask your symptoms, so that encourages you to do more. So by the time the injection's worn off, the damage in your symptoms are worse than they were beforehand. Very important paper published a couple of years ago showed that for every steroid injection you give into a knee, you increase the likelihood of that patient ending up with arthritis by 10% per injection.
Wow, that's a lot.
Yeah.
Very interesting. And Fiona has asked if she can refer herself. So I think the answer is probably email Ian. Anoop has asked, is there a place for an arthroscopy in a patient with advanced knee OA changes?
Rarely. Very rarely. This concept of an arthroscopic washout is very old-fashioned and it's pointless. If somebody's got mechanical symptoms, like they've got a loose body, I did this for a lady recently, just a couple of weeks ago. She's got fully blown patellofemoral arthritis, but she had really big multiple loose bodies in her knee catching, and her knee kept on giving way and locking. Her anterior knee pain is not bad enough yet to justify a patellofemoral partial knee replacement, but her mechanical symptoms were bothering her significantly. So for her, I did an arthroscopy, removal of loose bodies. Will it help with her patellofemoral arthritis and her anterior knee pain? No. Would it buy her extra time because she's now able to walk around and exercise without her knee locking? Yeah. So very rare, very specific instances. Otherwise, arthroscopy for arthritis does not work.
Yeah, understood. And then Charlotte's asked two questions linking together. Which tests would you use to diagnose a meniscal tear? And I was always told that due to the cost of the MRI and cutbacks within the NHS, conservative treatment for 6 to 8 weeks was best before referring. I presume that you're disagreeing with this.
Okay, so, right, I diagnose a meniscal tear by taking a history. Okay, and you can get a very, very good idea of just purely from the history, and then from clinical examination, which is a whole collection of different tests, and then from MRI. I would never operate on somebody on the assumption they've got a meniscal tear based on history and clinical examination without doing an MRI scan first. You know, that would be like that analogy of crossing a road with your eyes closed. You want to look before you leap. You want to know with as much certainty as possible what you are expecting to find and what you're likely to need to do before you go into a knee. Right. So for me, history, examination, MRI, and then the arthroscopy itself is diagnostic as well, because often what you find at arthroscopy, sometimes you find things that you weren't expecting to find. Sometimes, on rare occasions, you may go in expecting to find something and it's not there. So arthroscopy is diagnostic as well as therapeutic. And then in terms of the NHS, well, yeah, I'm sorry, but you know, you're kind of right, Charlotte, because if you're in a system that is rationing healthcare, well, then it's all going to be about creating barriers to reduce and restrict people's access to services to save money. And you can argue in terms of healthcare economics that saving money is good for the population. It means there's more money to spend on other things like kids' cancer, for example. However, from an individual perspective, restricting people's access to diagnostics is a bad thing, not a good thing. So in terms of that 6 to 8 week limitation, I think if that's a guideline within the NHS, remembering that, I'm sorry, but this is true, you're talking about a second-class service, and because of limited resources, well then, if it's a guideline, I'm all right with that, as long as a clinician, you've got the power to overrule that guideline, as long as it's not a protocol. Because if you have a clinical suspicion that there's something more urgent than that, then you should be able to refer regardless or in spite of that guideline. Otherwise, if you wait 6 to 8 weeks and somebody's knees get better, or somebody's symptoms disappear and they feel fine, well, you're probably better off just leaving them. So yeah, there is a place for those guidelines in context.
Thank you. Claire has asked you, once SONC diagnosed, how long does it take for the bone to recover?
How long's a piece of string? Depends on how bad it is. You get mild SONC, you get severe SONC, you get some SONC. Sometimes you may have to put somebody on crutches and an offload a brace, and it may take months for it to settle. Personally, I cannot remember in the last 20 years, I cannot remember the last time I operated on somebody for SONC. If you're patient, if you wait long enough, if you genuinely offload the knee, then SONC, if it's genuine primary spontaneous SONC, then it nearly always, I'd say pretty much always, settles on its own. It may take a little while, it may take ages. You just got to be patient.
Thank you. And Mauricio has asked you, have you got some articles that you could consider as essential to those having to have a better understanding of the knee? I don't know whether you mean knee anatomy there, but we have dropped in some links earlier on, but I don't know whether there's anything specific in or whether.
Well, that's like, can you quickly summarize entire professional career over the last 20 years in 10 words? Not really.
Best book you've ever read on the knee?
Best book?
Well, best
book.
article or...
Do you really want to send yourself to sleep?
Maybe.
Think
on that.
I would say look at those websites, all right? If you're interested in knees, just look at kneearthroscopy.co.uk or and kneereplacements.co.uk. I've put shed loads of info on those two websites.
Okay, brilliant. Thank you. And then the last question from Mark is I think this is an add-on. What about focused shockwave therapy for regenerative changes for the knee osteoarthritis? And then he's put in brackets, Institute of Regenerative Medicine in the US.
Is this a joke question or a serious question?
Mark, are you still there?
Right. So
probably serious, given that he's put it in.
I've given you my answer. All right. Shockwave therapy. There's some evidence that it may be useful for tendinopathies. Things like tennis elbow, golfer's elbow, that kind of stuff. Some of the sports docs use it for patellar tendinopathy, distal quadricep tendinopathy. Does it regenerate tissue? No, that's absolute bollocks. And I would say any organization that has got the word regenerative in its title, they're probably crooks.
Okay, thank you.
Okay.
There you go, Mark. And then Anoop's asked another question. Knee weight-bearing X-ray shows mild OA, whereas the MRI shows advanced OA. Is it something to do with the sensitivity of the imaging, or does it come down to the reporting of the radiologist?
Both. But that just emphasizes how important it is. If you see an X-ray with severe OA, don't bother with an MRI. If you get an X-ray with early OA, mild OA, or no OA, well then you haven't really got anywhere near enough information. So get an MRI scan. It's far more sensitive at picking things up. It will give you a lot more information. So I would rely much more on the MRI findings for that patient than the X-ray findings.
Brilliant. Well, that's all on the questions for now. Everyone's dropping in thanks, and I think we're about to hit time. So, Ian, thank you so much for your time tonight. It's been a fantastic presentation, and you're getting some great comments in there. The best ever webinar kind of comment.
The best webinar all evening. Way.
Best webinar ever. Thank you so much. Best webinar I can remember. There you go. So thank you so much for your time. Really, everyone appreciates it. You had about 80 people on listening to you, and we really do appreciate it. So thank you. Ian's details are up there if you have any more questions or any referrals, and we look forward to seeing you again on our next webinar. Thank you, everybody, and thank you, Ian.
Thanks a lot. Thanks, Lizzie.
Thank you. Take care.
Take
Bye.
care. Bye.